This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
All right, we're recording. Welcome back, buddy.
Welcome. Thank you. Thank you for having me.
I am excited to go over this paper that you actually texted me about, and I'm thinking about titling this on like a journal club.
That's what I was
maybe
too. Because I think it is important to have like pre-hospital journal club also. Like
yeah,
a lot of articles.
I wonder if we can call it like a. Oh, sorry, you're fine. Go ahead.
Yeah,
why is my
internet? There's a lot of journal articles in the pre-hospital space that I think we need to, obviously I'm in hospital now, but like pre-hospital providers also need to stay up on current literature and current recommendations and everything. So I think it's important for everyone to kind of look into the literature as we go forward in our careers.
You'll always be pre-hospital to me, buddy. I don't care.
My certs have expired. I am officially no longer pre-hospital. Although my fire is still active.
Yeah. Because fire is always active, right?
I can get on the brig. I can't get on the ambulance.
some would prefer it that way. All right, so we're going to review the INTERACT4 trial today. Do you want to give us a little bit of foundation before we get started?
Sure. So this article was published in the New England Journal of Medicine earlier this year. I want to say about back in May of this year. So we're going on 5 months or so. That's been published, and it's a study out of China looking at a more intense blood pressure regimen control pre-hospital, leading into going into the hospitalization in patients with an acute stroke picture based on a FAST score of 2 or more. So for patients to qualify for this study, they had to have a blood pressure greater than 150 systolic and had to have a FAST score, so facial droop, arm weakness, slurred speech, and then the T was time. It had to be within 2 hours, a score of 2 or more to qualify for this trial. Had to also be over the age of 18. And the thought process of this trial, the kind of background for why they wanted to run it, was because there's been some kind of variable literature out there about a more tight blood pressure control in the setting of acute stroke. From a hemorrhagic stroke side, so any kind of intracranial hemorrhage, blood in the brain, we typically have a tighter blood control. The current critical care literature looks at a blood pressure of 160 or less. Some people say 140 or less to kind of help prevent expansion of that hematoma in the brain. But with ischemic stroke, we typically have a more slightly liberal blood pressure. So they're kind of seeing if having a lower blood pressure actually improved outcomes, catching those patients in hemorrhagic stroke, catching them before the hematoma expands to keep their blood pressure tighter, but without compromising the ischemic stroke patient population. Because obviously pre-hospital, we don't really have a CT scan, and we're not going to load up a patient and scan their head on going into the ambulance to know if it's an ischemic or hemorrhagic stroke or not. So that's kind of the background to the study. Like I said, patients over 18 had a FAST score over 2, systolic blood pressure over 150, and they're looking at a modified Rankin score, which is kind of the severity of neurologic compromise or deficit 90 days after the stroke. That was their kind of primary outcome, as well as some secondary outcomes, and looking at the subgroups of hemorrhagic stroke population and ischemic stroke population. And basically what they found was there was really no difference in the modified Rankin scores at 90 days between the tight blood pressure control group of 130 to 140 blood pressure goal and the more liberal blood pressure group, which was where they started treating blood pressures as if they got over 180. And that was kind of the 2 treatment arms that they looked at. And so they used a IV medication that is apparently only available in China, it sounds like, and it works on alpha receptors and the 5-HT system for the serotonin side of the blood pressure control. And so they use this medication as a apparently very rapid onset blood pressure control medication to bring the blood pressure down. And then, like I said, once they found no difference, although looking at the subgroups, they did find better outcomes based on modified Rankin scores in the hemorrhagic stroke population compared to the ischemic stroke population. So the patients in the hemorrhagic stroke arm of the treatment arm had better modified Rankin scores than the ones in the control, where they only treated the blood pressure if it got over 180. And then ischemic stroke, they found no different outcomes.
Oh, sorry.
Yeah, go ahead.
No, it was just interesting. I just brought up the paper next to me. It was interesting. So just a little bit more detail on the paper. So there was 2,404 patients enrolled in total, correct?
Yep.
Hold on, as I scroll down to where I'm looking at in my notes. With a mean age of 70 years. Let's see. Did you talk about the intervention group versus the usual care group yet?
So I mentioned that they want to have a tight blood pressure control, 130 to 140 with this IV medication.
And then the control really was just doing what they normally do, right?
Yeah. Standard of care, treating blood pressures over 180.
And what was interesting to me was the patients that were included had to have stroke symptom onset within 2 hours, which was very interesting to me. And then you mentioned the results. So the patients were included. Do you want to talk about the randomization a little bit, how that occurred?
Sure. So the randomization was in a 1-to-1 process. Let me pull it up here in my notes here. So they, based on like I said, their FAST score. So once they met inclusion criteria over 18, blood pressure over 150, they had physicians on every ambulance. This was for the most part, sounds like hospital-run EMS system in China that is all staffed by physicians. And so they were randomized in a 1-to-1 ratio to either receive the blood pressure control or the more standard of care treatment. And then it was used a web-based system that kind of included minimization algorithm to minimize a vast variation of patients. So like patients under 65 were basically randomized in a 1-to-1, and patients over 65 randomized in a 1-to-1. So that way it wasn't, ironically, every other patient was 75 and and then the intervening patients were 50. So we had a very dichotomous age discrepancy. So that was the way that they kind of randomized patients around.
Okay. Let's see here. I'm getting a little bit of weird mic stuff from you, like your mic's randomly cutting out. I'm not sure why that would be happening.
There might be traffic outside that is honking, and then my mic kind of
cuts
mimic
out. Okay.
Cut out the excess sound.
It's not too bad. But
I can put headphones in if you need me to.
Would that affect the mic?
No, because my mic is on my headphones. So I don't think. We were just talking about the randomization.
Oh, okay, yeah. Sorry, go ahead.
We just finished talking about the randomization. Another thing I found interesting was patients were kept in a horizontal position.
Oh yeah.
Instead of like a
semi-Fowler.
Yeah, semi-Fowler position. I forgot the name of it. I usually think of trend and reverse trend. Yeah, instead of a semi-Fowler position, I just found that a little interesting. I don't know if it was thought about cerebral perfusion, if that was the process behind it. They didn't really comment on why. It's just like that was the way that they did it.
And so what's interesting to me is like patients that have like severe head bleeds, putting them flat is like very concerning, right? Like there's like things like there's like procedural things that people can do to, like, if they need to get a CT scan, like they can give like saline bullets and stuff, right? To like just procedurally get them enough so that their head doesn't ever. So it was interesting to me that at baseline they were okay with putting them horizontal.
Yeah, I don't know if it has to do with perfusion or like what, if that was the thought process. Because I mean, we typically have patients at 30 degrees unless we have to, like you said.
And they always say that, like, if you think your patient's having a head, like a bleed or something, like sit them up as much as you can, right? Because let gravity do its thing. So I don't know.
It helps decrease the hematoma.
Yeah, I don't know. All right. Where do you want to go next with this?
So I guess we can go into the results that they found.
Yep. Yeah, let's do it.
So I kind of summarized it in the very beginning, but more in-depth look at it. So like Mustafa said, they randomized initially 2,400 patients, so 2,425 patients, ended up including 2,400 in the end analysis because they lost some patients to follow up. Some patients rescinded their consent after they were initially randomized into the process. And so all in all, they lost about, sounds like 19 patients or so to that process. So they ended up with just 2,400 patients that were included, which is more than what they wanted for a 90% powering of the study. So they did at least hit their mark of what they wanted to do to say, well, we would get statistical significance if we found statistical significance. And so totally there was, like I said, there was 1,200 enrolled in the treatment arm. So 1,205 in the the treatment group, and 1,199 in the control group, the standard of care group. And then what they found was the mean systolic pressure for patients that arrived to the hospital in the control group was 178 millimeters of mercury, plus or minus 21 millimeters of mercury. And in the treatment group, which is the group that had a stricter blood pressure of 130 to 140, they actually found that the blood pressure was I apologize. The 178 was the at randomization. That's the average blood pressure at randomization. The systolic blood pressure in the treatment group when they arrived at the hospital was 159 millimeters of mercury, plus or minus 26, and in the standard of care group was 170 plus or minus 27 in the usual care group. So that, I don't want to go too much into the discussion of it, but that is one thing that kind of was a red flag for me when I was reading the study, was the separation of the blood pressure at time of arrival to the hospital was not that significant. The standard deviation overlapped significantly, which kind of tells me that the blood pressures were not statistically significant different at time of arrival to the hospital. And I mean, just from a layperson, if I say blood pressure 160 versus a blood pressure of 170, really not much of a difference.
Not much of a big deal, yeah.
Especially since the goal was the blood pressure between 130 and 140.
Mm-hmm.
So they did not quite reach their goal at that point. They did comment, though, that the estimated difference between the treatment group and the control group during transport was about a negative 15 millimeters of mercury, which means that they felt that they got a difference of 15 millimeters of mercury between the two groups throughout the course of the transport. And this was kind of commented on in the supplemental text of the paper, where they had a decent graph that showed a pretty good separation in the treatment arm versus the control arm. That kind of then, as we got closer to the time at the hospital, showed a significant more overlap of the standard deviation. So I don't know if that goes into, kind of like what we experience in the United States with transfer times being different depending on your principality, wherever location you're at. You might have a 10-minute transport where you can give one bolus of this medication, and by the time you get to the hospital, the blood pressure is low because you're at goal because you hit your mark. Or it could be a 25-minute transport where you give a bolus and then you're cycling the blood pressure, and at the time of the next bolus, the blood pressure is high, but you're at the hospital. So I don't know if that's a component of why there was such a discordant number of blood pressure readings from the pre-hospital versus the time arriving at the hospital. But that was just one thing that kind of stuck out to me as I was reading this article, was that at the time of arrival to the hospital, the blood pressures were not that separate.
Mm-hmm. So I guess the variation then came in just because of the amount of pressures that they had. So
I can pull up the graphs right now if you want me to.
Yeah, sure.
Yeah, from the supplemental. All right, and so this is the differences in systolic blood pressure. The red, I'm assuming color shows up pretty well here. So the red is the standard of care group, and the blue is the treatment group. And as you can see, at the time of randomization, so that's what the R stands for, is randomization.
Mm-hmm.
At the time of randomization, blood pressure was about 178. plus or minus 21. So that bracket would represent that 21 millimeters, or no, don't worry about the 20, but like that represents the standard deviation of all the patients that kind of are in that category. And then as you see here, the standard of care group kind of dropped to a blood pressure of about 170, maybe 169 here, and then kind of plateaued in this general area. And then in the treatment arm, blood pressures dropped more significantly down to 150, probably to about 147 or so. And this is the time from randomization up until the point where they hit the hospital. So this HSP stands for hospital. And then if you look down at the bottom of the graph here, the numbers tells you how many patients. So this was the number that were randomized into the each group. So the 1,199 in the control group and the 1,205 in the intervention group. And this kind of tells you the next blood pressure readings that were received. So in this here, you had about 55 or 60% of the patients had a blood pressure reading. Less than that here, closer to a third or maybe a little bit more. A third of patients, a third, and so as you got farther out from time of randomization, a lot less patients were getting blood pressure readings. So that means the transports were, for the most part, 10 to maybe 15 minutes or so for transport.
Yeah, that's interesting. I didn't read it. Yeah, because I didn't look at the supplemental material at all. Yeah.
And so this is a nice way to kind of look. And so maybe these patients on longer transports, they were able to get the blood pressure better controlled. But then here, this is the time that they reached the hospital. Here, you can see that the blood pressure, this is the 170 plus or minus 27.
Mm-hmm.
And this here is the 159 plus or minus. Yes, this is the 170 plus or minus that. But they got very discordant here. And so the graph suggests that there is statistical significance and difference at the time of the hospitalization arrival. The way the standard deviations work. I mean, the first standard deviation, about 90% of patients are going to be in those. About 55% of the patients are going to be in that first standard deviation or so.
Mm-hmm.
And so for plus or minus, so the standard deviation being so wide, anywhere from 133 to 100 and what? This is going to be 85. So, there's no way that this wasn't, in my opinion, statistically significant difference here at the time of hospitalization.
Mm-hmm.
But like I said, they do show a nice separation of blood pressures during transport. Like I said, as you get kind of farther into the transport, less and less patients are getting vital signs checked, likely because they all arrived at the hospital.
Yeah, and just for folks who, for the term standard deviation, just think of it as like a way to measure how spread out or different the numbers are from the center, right? From the average. So it's just, it gives us a range of how similar or different all of the values in the data are. It's useful because for these blood pressures, if you have a wide standard deviation, that means you have like a wide variation, right? Would that be a safe way to say that? I wanted to make sure I didn't say the word variance, because that's actually that's something else. But when the rubber hits the road, we're seeing a ton of overlap between the patients that were in the control group, which is where nothing should have been done different, and the intervention group where we were giving this new medication. Did I summarize that appropriately?
Yeah, so like you said, so the wider the standard deviation, or the larger the standard deviation, means that the wider of all of the numbers that are. So the way standard deviation works, by the time you get third standard deviation, you should capture 95% of the population that is in that standard curve, if you think of a bell curve. So that is what we're trying to capture here, is understand how far spread out these things are. And so, like I said, one standard deviation should capture about 68% of the patients.
Mm-hmm.
And so that is why we use standard deviation to kind of help get an idea of, so that means anywhere 68% of the patients at the time of arrival at the hospital in the treatment group had a blood pressure from 133 millimeters of mercury systolic all the way up to 185 millimeters of mercury. And then in the treatment arm and the control arm, 68% of patients had a blood pressure of 143 millimeters of mercury to 197. So that's kind of the way standard deviation works in a normal distribution. So understand this is probably not a normal distribution of patients. It'll probably be skewed a little bit, and there's different mechanism looking at that. But just by 68% of patients should fit in that bracket of where the blood pressures are. And then you start getting more discordant. But by the time you get 3 standard deviations, you should have about 95% of the entire number should fall in that bracket.
Yeah. So what are the take-home messages from this this project, this analysis at least?
So, I mean, I guess the take-home is that we still don't have a great way of knowing if we should treat blood pressure or not, because in terms of the primary outcome, their odds ratio that they calculated for the treatment versus control group was an even 1.0. I don't know if I've ever seen an odds ratio at 1, which means that means there's literally no difference.
Yeah, I've never seen that before in my life, which like kind of I don't know. It just was like, oh, interesting.
Yeah, so to kind of summarize what an odds ratio is the likelihood that the intervention that you did made a difference. And so if it's less than 1, that means that you made a difference. If it's more than 1, it means you did harm. And at 1 is kind of the standard of you did nothing. 1 is you did nothing, and that is where your kind of baseline then moves left or right depending on if you caused harm or good. And so the fact that their odds ratio is right at 1 suggests that really no difference happened. And then when you look at it, when you break it down from the hemorrhagic stroke versus the ischemic stroke, they did find a benefit in hemorrhagic stroke with an odds ratio of 0.75 in their confidence interval, which means that 95% of the likelihood of whether or not it would fall in that category is 0.6 to 0.92, which makes it statistically significant. Mm-hmm. So as long as your confidence interval doesn't cross 1, because once again, 1 is kind of, you did absolutely nothing for the patient. Like it was just what your control is. They proved benefit in a hemorrhagic stroke population with blood pressure control. But in the ischemic stroke, their odds ratio was 1.3. So so I guess the take home is we unfortunately don't have a good answer for what to do with patients with acute stroke. And I think that comes down to the mechanism behind each stroke. So ischemic stroke versus a hemorrhagic stroke, there's very different mechanisms behind both of them and very different treatments that we provide them in the hospital, and for very good reason of why we do that. So I think that's kind of the takeaway is get them to the hospital as fast as you can so you can diagnose it and then treat the patient. Because obviously this study was looking at if we intervene from the time of healthcare contact as opposed to time at the hospital, are we improving outcomes? Because I mean, if you think about it, door to balloon time and myocardial infarction, or any time to plunger and pulmonary embolism, massive pulmonary embolism, or MI that they're not going to get angiography for. Mm-hmm. There's so many things that we're trying to shorten that window to help improve outcomes. And this is one of those studies looking at, can we improve outcomes by starting treatment sooner in the pre-hospital setting as opposed to waiting till they arrive at the hospital? I mean, because there were 60 some patients in the treatment arm and 30 some patients in the control arm. So 100 patients about that had an hour transport at the time of diagnosis, at the time of randomization into this thing. So an hour, that's a significant amount of brain time. And as we know from ischemic strokes, your TPA time is 3.5 to 4 hours. So if you are diagnosed at 2 hours and you have an hour-long transport, that you don't have much time to make meaningful outcomes if it is a TPA candidate.
So let me ask you something. From my understanding, though, like 75% of strokes are ischemic, right?
Yeah.
And do you anticipate similar population dynamics in where these patients are?
So they commented on that in the discussion. And when I first read it, I will admit I was post working a night shift on a plane to a medical conference, and I misread the sentence that they said. But when I reread it, it's the way they word it, it comes off weird, but it sounds like they have higher incidences of intracerebral hemorrhages in China. The sentence was, this trial was conducted only in China, where the proportion of cases of acute ischemic stroke caused by intracranial atherosclerosis and cerebral small vessel disease is higher than in North America and Europe, and where the incidences of intracerebral hemorrhage is high. So I think when I first read it, I thought they said that the incidences were higher in the Western civilizations, America and Europe, of intracranial hemorrhage, because they had 42% of their patients end up diagnosed with a hemorrhagic stroke.
Mm.
And according to the AHA, I when I read that, I was like, I was dumbfounded. I went to the AHA website and confirmed it. 20% or so strokes are considered hemorrhagic in the United States.
It's interesting to me because they allude to cerebral atherosclerosis and such as the same mediator, right? The same cause, but then I don't know. I just find it interesting that they would say that that's the reason that there's an increase in hemorrhagic strokes, but those are also the leading causes of ischemic stroke, right? When we think about metabolic illness and baseline epithelial damage caused by smoking or diabetes or whatever. So it's interesting to me that they would come out with that the same reason, but for a different stroke.
Well, I will say in the smaller vessels, the perforating vessels of the lacuna region of the brain, so like off of the middle cerebral artery, when it comes off of the circle of Willis, has small perforating arteries that go into the deep parts of the brain.
Sure.
That's a common place for hemorrhagic stroke. And high blood pressure and atherosclerotic disease can cause to rupture of those vessels. And so it's usually high blood pressure that causes that, but atherosclerotic disease would probably associate with that as well. The way that they worded that was a very weird takeaway for me. I agree that hemorrhagic stroke, like I said, they had 42.6% of their patients have diagnosed with a hemorrhagic stroke, which is very high compared to the United States.
Yeah, I guess what I'm saying is I wonder what causes that difference is basically what I'm trying to say, because when I think of like atherosclerotic like hardening, and what we mean by that is like basically like high cholesterol hardening of arteries, right? That's what we mean by that. Why would we have the same issue in the United States, right?
Yeah.
So like that's why I was like, I wonder why our
So I'm wondering because America also has a high incidence of atrial fibrillation and large vessel occlusions from cardioembolic causes.
Interesting.
So that might be what they're alluding to there.
What would cause that? I mean, like if there's
a cardioembolic cause of stroke?
Yeah. Well, no, but like what would cause a patient to have more like, I guess, atrial fibrillation then?
Well, I don't know. I don't know. If that's what they're alluding to, because like they don't comment on large vessel or like cardioembolic cause. The fact they mentioned intracranial atherosclerosis and small vessel disease is basically excluding cardioembolic causes. So patients with atrial fibrillation, an LV thrombus or left ventricular thrombus in the setting of a low EF or low ejection fraction, heart failure, or a patent foramen ovale, DVT, stroke that crosses over from the right side of the heart to the left side of the heart. So those are all things that are cardioembolic causes of stroke that they don't comment on there. So I think that's maybe what they're getting at, is that they have more of like a atherosclerotic disease ischemic stroke, and we may have a higher large vessel occlusion cardioembolic.
I'd be interested in looking at that actual data.
Yeah, same here.
Because it seems like, I don't know. I won't comment on the authors, but I don't know. It sounds like a huge assumption. But yeah. Also, I guess I'm just a little dumbfounded as to there was 2,400 however many patients put through a trial to show us something that we already kind of know, right? I mean, and I'm not saying that their research question wasn't a good one, but like obviously, so in the subgroup analysis, right? So patients with a hemorrhagic stroke had better outcomes with pre-hospital blood pressure reduction, and patients with ischemic stroke showed worse outcomes, but essentially, right, in the sub-analysis.
I agree. And they did reference, so they referenced to a couple trials in the beginning in the introduction section that kind of hinted at why they needed more investigation. So there's the Right 2 trial that showed that patients receiving a transdermal patch to reduce blood pressure.
Transdermal glycerol trinitrate.
Yeah. Showed no improvement compared to a sham patch. And then there's the I want to say that it was the INTERACT4 that they commented
Was it Mr. ASAP?
Oh yeah, the Mr. ASAP showed
Yeah.
improvement.
No. So it's the other way around. So Mr. ASAP showed they actually had to finish it earlier because at 380 patients they found that there was a higher mortality from intracerebral hemorrhage with the use of transdermal glycerol trinitrate. And then the Right 2 trial showed no effect of a transdermal glycerol nitrate patch as compared with a sham patch in the intention to treat population, but that's like basically the intervention group. In the subgroup of 142 patients with intracerebral hemorrhage, those who received the glycerol trinitrate patch had worse outcomes than those who received the sham patch. So,
yeah.
I don't know. I'm just seeing a bunch of harm here.
Yeah, so they wanted to, I guess, further define, because I mean, you can't make too much of a comment on a subgroup of 140 patients.
Yeah, no, absolutely.
So that's why they wanted to kind of further define that, and also using a nitro as opposed to an alpha, like an alpha 1 5-HT1A.
Yeah,
like, different mechanisms have different rationales for why they would have better benefits.
And let's go into that a little bit. So nitroglycerin, we know that nitric oxide is a local vasodilator, right? And that's what those were the two. I imagine those would have then disassociated into nitric oxide, right? It's essentially both patches.
That's what they did.
Yeah. Whereas for what's the drug? The urapidil has a combination alpha 1 and the serotonin receptor. Was it 5-HT? We can go into that a little bit.
5-HT1A.
Yes. So let's talk about that a little bit. How does the blood pressure reduction work with their drug of choice?
So our blood vessels have an alpha 1 receptor on it, and so alpha 1 agonists will cause vasoconstriction. So if you think of our norepinephrine as a vasopressor, or phenylephrine is the other one that are commonly alpha receptor agonists. So they activate alpha 1, causes vasoconstriction. So this is the opposite. It's an alpha 1 antagonist. And so it attaches and causes vasodilation of the blood vessel in that local setting, preferentially on the arterial side. And then the 5-HT1A is a similar process that reduces vasoconstriction. Last time I was on, we talked about serotonin syndrome, and hypertension is one of the things in serotonin syndrome. High serotonin causes high blood pressure, and 5-HT1A is a serotonin receptor. So blocking that also reduces blood pressure as well.
Yeah. Well, this was a 5-HT1A agonist, correct? So what it did was I believe the tone induced by that 5-HT1A receptor then inhibits sympathetic activity. So that reduction of sympathetic activity then can lead to like the vasodilation, the decreased heart rate, so on and so forth. I had no idea what this. I mean, I know about 5-HT receptors. I have not heard of 5-HT1A receptors since my physiology classes, so it was helpful to do the review. Is this a novel drug? Do you know about? I mean, from when I was reading the paper, it seemed like it was already like
widely used in China.
Widely used.
It's not as wide use in China. I don't know if it's anywhere else in the world. Obviously, it's not in America, but it sounds like kind of wide use in China. The other thing I found interesting in the study was standard of care for ischemic strokes in China is blood pressure of 160 from the time of diagnosis, which kind of varies from the American model of blood pressure management in ischemic stroke. So I kind of found that interesting. I don't know. I'm not going to speak to the literature over there that they're using for it, but I just found that kind of interesting as a, from an American physician standpoint of blood pressure control in stroke. I typically am a lot more liberal with my blood pressure guidelines. If a patient is not a TPA candidate, tenecteplase and alteplase candidate, I usually let their blood pressure rise to 220 for the first 24 hours. And the thought process that at least here in the United States that we use is the higher blood pressure increases our cerebral perfusion pressure, which helps collaterals to kind of go around whatever area of blockage, be it small vessel. Typically, these are more small vessel, atherosclerotic, non-large vessel occlusion that they get intervention on. Increase the perfusion around the blockages to improve the perfusion of the ischemic area to minimize the risk, the risk of loss of that region. And typically we do it for 24 hours and start to gradually normalize the blood pressure after that. And then if patients start developing symptoms or having evolution of stroke, when we start to drop the blood pressure, we then bring their blood pressure back up to help that perfusion and kind of repeat the cycle and see how they do. And then with hemorrhagic stroke, we kind of talked about at the beginning of the episode, blood pressure goal between, some literature says 160, some literature says 140. I kind of cut my right in the middle, go 150-ish or less to reduce the expansion of the hematoma that's in the brain. And so it was kind of interesting, like I said, the difference of the management of stroke compared to the United States and China.
I mean, essentially, you're with aggressively treating hypertension and ischemic stroke. You're essentially killing the patient because you're taking away the whatever compensatory mechanism they have for perfusing the bits of brain, right, that you do have.
So I don't know
if you do it aggressively, right? Because I see that as the same thing as like water shedding a healthy patient that's hypertensive but asymptomatic.
Yeah, I agree with that. So if you drop it too aggressively, I think 160 is not a too aggressive of a number.
Yeah.
And I don't know if, based on the fact they had 42.6% of patients having hemorrhagic stroke, I don't know if they have a higher amount of conversion to hemorrhagic strokes if they have higher blood pressure goals, because that is a risk that we run with higher blood pressure, is that stroke could convert to a hemorrhagic stroke, even without getting TPA or other kind of lytic therapies for the stroke. So I don't know if that's a component of why their blood pressure regimen is a little bit more tight controlled compared to the United States. Because, like I said, 42.6% hemorrhagic stroke in this trial is ridiculously high. And they commented, it makes it sound like that's kind of normal for them, it sounds like.
Yeah.
So that might be a reason why. Going back to the kind of the perfusion of the brain, we kind of alluded to it. Blood pressure is very important for perfusing the brain, and that's based off of our mean arterial pressure minus our intracranial pressure, and those two kind of produce our cerebral perfusion pressure. So if you have a very elevated intracranial pressure, which can happen with hemorrhagic strokes, especially if there's a large hematoma that is increasing. If you think about what the Kelly-Monroe doctrine that has the three, it's a triangle with three components: blood, parenchyma, CSF, and then if any one of those three components shift, it's a fixed box, and so everything else has to shift to accommodate for it. So CSF goes down, brain parenchyma goes down if the blood goes up, or if the parenchyma goes up, blood has to go down to accommodate for it. So you want to prevent the expansion of the hematoma by lowering the blood pressure, but you don't want to lower it too low because obviously you still want perfusion of the brain. And then with ischemic stroke, kind of going the opposite, you want the blood pressure to be a little bit higher to really perfuse the brain, to try and get around that blockage and, like I said, help with the collateral flow to areas of the brain to minimize the damage of that. So the term is the penumbra. The penumbra in the brain for doing a stroke is kind of the vulnerable brain. So you have a core infarct, and then around that you have the penumbra, which is kind of the at risk brain tissue of loss of function, if the risk of ischemia, and then you have like kind of the lower risk and then normal tissue. So the goal is to kind of minimize that penumbra, make the penumbra as small as possible by having the blood pressure up to increase the perfusion of that area.
It's where Maryland is in the talks of adding labetalol for symptomatic hypertension and a few other indications. Or the early conversations, right? What are the symptoms that you as a physician look for in a critically hypertensive patient that is like the primary issue is the hypertension that then leads to symptoms that may look like a stroke, compared to a patient that is having a stroke and has a resulting hypertension? What are the differences there?
That is a very good and loaded question. The issue is it's kind of hard to tell. So I've had patients that have come into the hospital with severe chest pain and the blood pressure is 215. You're like, all right, that's probably what's going on. And then not having aggressive enough of blood pressure treatment, then they start developing neurological symptoms, and it mimics a stroke. Like they get one-sided deficit, they get numbness on one side, they get weakness on one side, and so they would have some overlap. And so, especially in the pre-hospital setting, I mean, it's hard enough in the hospital setting with diagnostic tools, CT scans, MRIs, everything else that we have. It's very hard in the pre-hospital world to kind of say, is this a stroke or is this hypertensive emergency? I typically look for end organ damage, which fancy word of saying if they're having severe chest pain, severe shortness of breath with a blood pressure, over 180 plus all these other symptoms, altered mental status, or just global weakness, anything like that, it would be more likely to be a hypertensive emergency than a stroke. If it's unilateral, I would probably be less. Obviously, I don't know what Maryland protocol is going to say if it does roll out. I'm a huge fan of IV labetalol in hypertension patients. I think more hospital medicine floors should be allowed to do it than they are. So I think it's a rather safe, has a pretty well regulated blood pressure effect.
Mm-hmm.
Like it doesn't tank the blood pressure like some other IV medications that we can give. So I think labetalol is a safe,
like hydralazine.
I didn't want to say it, but yes. So you get a slightly more controlled blood pressure drop. So you might go from like 190 to 170, 160, and like it's still going to be a good perfusion pressure if it is truly an ischemic stroke. But if it is a hypertensive emergency, you're going to get a little bit better control of that hypertensive emergency earlier.
Okay. So let's take I think we've done a pretty thorough review of the paper. Now let's do an analysis and a critique of the paper, if that is okay with you. Let's talk about some of the strengths and some of the weaknesses, and after that, how we can use those strengths and weaknesses to assess the validity and the strength of this and the impact of this paper. And for our listeners, I want them to, I want you guys to really use this as a surrogate for how to analyze any paper, right? I mean, this is something that, Dr. Brady and I were talking about before we start recording, doing more journal clubs. I think that'll be number one, kind of fun. But also it helps us become more like research literate, right? Because certainly I didn't know what I didn't know, quite frankly, until I started my graduate program in epidemiology, right? So let's get started with that.
Yeah, of course. So I think some of the strengths, I think it was a really well-powered study. So powered means that they're looking, trying to find a statistical significance. They felt that they would need to enroll 2,400 patients to show a true statistical significance if there was going to be one. And they, plus the possibility of dropout of patients, plus the possibility of there not actually being an ischemic stroke. And it was just kind of maybe a hypertensive emergency or something else that was going on that was not truly a stroke-related high blood pressure. So they think they powered the study very well for that. Sounds like the strong strengths that they comment on is that they adhered to the protocol well. I agree that based on what I've read in the supplemental and everything, the medication was bolused as it was supposed to be when it was indicated to be bolused. Based on the blood pressure readings at the time of arriving to the hospital, I'm not 100% convinced that they adhere to the protocol as well, because they want to get the blood pressure to 130 to 140, as opposed to the 158 or 159 that it was when they arrived at the hospital. So I think that was maybe more of a weakness than a strength that they commented on. Another comment that they made for their strength was the ability to lower blood pressure effectively with a simple intravenous treatment regimen, which I agree. They, based on the supplemental graph that I showed you, they did have a significant drop in blood pressure very early on in transport after administering this medication. Now, with that being said, some of the weaknesses about this trial is this trial was funded by the pharmaceutical company that makes this medication, and they had no role in the protocol or the running or the randomization of the trial itself. Like they made it very clear that it was in part funded by this company, but it was just that. With that being said, whenever pharmaceutical companies fund studies, I always kind of maybe go through the study with a little bit more of a fine-tooth comb than I should. And I was like, the line, the lower blood pressure effectively with a simple intravenous treatment regimen, I agree that it did do that, but that was not really the aim of the study. The aim of the study was to see if there was a benefit in dropping the blood pressure. And so they kind of commented on that. I don't know if it was for the benefit of the pharmaceutical company. I don't want to get into the minds of the authors of this. It was just kind of, it came off weird.
And nor is that a novel thing at this point. We have plenty of IV and oral agents, like you said before we were recording, that are very well documented to reduce blood pressure in various degrees.
Now, I will say, compared to the nitro transdermal patch studies that we commented on earlier, it did not cause harm and did not have to terminate enrollment early. So, kind of devil's advocate to that comment, I agree that, yes, we have a lot of IV medications that are very effective and relatively safe. This one showed benefit over the other studies that they commented on in the introduction that showed that there wasn't harm in lowering the blood pressure with this medication.
I mean, do they not have labetalol over there?
I don't know. I don't know the pharmacology or the formulary of the hospitals in around the world. I know my hospital. I hardly even know my formulary, and it changes rather frequently. Another weakness of the trial, once again, I think, like I said this before, 42.6% of the patients in the trial were hemorrhagic stroke patients, which, based on the AHA publications from 2023, the United States has a roughly 18 to 20% hemorrhagic stroke population, so they have about double in this trial. And kind of going back to what I said earlier, treatment for high blood pressure in hemorrhagic stroke is you drop it. Treatment for high blood pressure in ischemic stroke is you only treat it if it's over 200, 220, if they do not get to place or out to place. So there is a large discrepancy in the type of patient population that they saw in their study compared to a United States population. So that was another kind of weakness of this trial. Like I said, I think it showed it had a lot of benefit out of this trial in showing us that we as pre-hospital providers still don't have great treatment options for acute stroke because of the dichotomy that is the hemorrhagic versus ischemic stroke quandary that we find ourselves in. And without the ability to diagnose that pre-hospital, I don't know how much we'll ever have a treatment that will be helpful, because they are treated differently depending on which type it is.
Yeah. Maybe I'm biased because the baseline, how should I say this? The baseline circumstances that I am used to dealing with in the United States is that the vast majority of our strokes are ischemic.
Mm-hmm.
So with that lens, I find it difficult justifying treating undifferentiated stroke with hypertensives in a study population, like from an ethics perspective.
So I agree with that from the lens of an American provider.
Yeah.
But once again, their trial.
No, and that's what I was going to comment on, right? Like
was 50% of them. Almost 50% had hemorrhagic, so it's 50-50.
Yeah. So, but what what I was getting at is, there's this research, good research. Not saying this isn't good or bad or anything, but like good research is generalizable.
Oh yeah.
Right. And the word of caution that I would give folks is when you're reading a paper, there's a million variables, right? That I I don't know what I don't know, right? But as I'm growing in EMS and in epidemiology and learning, becoming hopefully a little bit more research literate, I'm learning the impact of generalizability when planning a study, right? Now that I'm like I'm in the crawl, walk, run scale, I'm crawling into doing my own research and leading research projects. Someone who reads this may, without having the I guess the proper framework, may not realize the impact of generalizability. And if we were to take this paper and utilize it as one of the references to develop a protocol, for example, to treat hypertension, we could potentially do a lot of harm, right?
Mm-hmm.
And that's why, one of the many lessons of this podcast is a paper is never enough, right? One study is never enough. even in the beginning of this paper, they describe all the research, the baseline research that they were trying to add upon, right, or improve upon. So, yeah, no, that's but it's certainly an interesting paper. I'm going to scroll up on my notes here. The what was I going to say? Oh yeah, that's what it was. I just wrote here Urapidil everywhere? Question mark. It certainly. I don't. Do we have drugs like this with similar mechanisms, like with combination mechanisms in the U.S.
So
that you know of?
not with alpha 1 5 HT1A. I know we have plenty of alpha 1s. Clonidine a common one that I think about. That's a oral pill, but and transdermal patch. But clonidine is the most common alpha 1 that I can think of that we use. And then Hydral has an unknown mechanism of action. Hydralazine has an unknown mechanism of action that is felt to be along that spectrum, but it's not really known 100%. But for the most part, especially IV medications, is typically one mechanism, either a beta blockade with labetalol, enalapril is a RAS inhibition, so an ACE inhibitor, and then nitroglycerin IV is obviously the PD process.
Yeah. And I mean, apart from that, I mean, I think it's a decent study.
Yeah,
apart from a couple things, I agree with your hesitation when it comes to that. The little random line of, "Oh, this is a good drug," or I don't know, maybe the pre-hospital setting is a market that this company is trying to introduce, get into. I don't know. I mean, if you're the researcher, what would you try to do next?
I mean, that's a very good question. I mean, I think from this standpoint, I don't know if it's worthwhile to continue down this specific blood pressure control. I mean, you have the first studies in the beginning that they comment on caused harm. This one showed no benefit in this route, like this formulation of medication.
Let's just say if I was NIH, I'd be researching funding to get better scanners.
I mean, portable. I mean, so there are portable CAT scans. They just
I know. I'm just thinking of, like, I don't know, the sci-fi version of this, right? Which certainly, I'm not an engineer, so I have no idea how close or far we are from that. But I don't know. It seems to me. So the way I think about it is this: either we get better imaging, right? But what do we use for imaging, right? What's the purpose of imaging? The purpose of imaging is to diagnose what kind of stroke we have in this scenario. What if there were other ways to just figure out what kind of stroke the patient was having, whether it's an undiscovered biomarker, whether it's I don't know, some sort of other sensor, like a pressure sensor or something, or anything. I don't know. I'm like shooting, I'm shooting from the hip here.
I mean, standard of care right now is a CAT scan. Who knows what will be in 20, 30 years? I mean, it's CAT scan to rule out hemorrhagic stroke before you go down the route of tenecteplase, or alteplase. And another comment I want to make for the readers, just the listeners, just in general, is if you're going into this and get excited about, I want to be more up on literature in my space, remember that negative articles can be just as telling as positive articles. So just because it doesn't show a difference does not mean that there isn't something to learn from that article in terms of how to manage patients. Right. So that's another thing I want to kind of to plug in there. Just because this article showed no difference in outcome does not mean that there's something to not take away from this article in terms of management of patients. This one, like I said, it's difficult because depending on the type of stroke, has very different treatment decisions branches in the hospital. So understandably, dropping blood pressure helps one but hurts the other, which they showed. Right. So just because it's a negative study does not mean that it's not something to learn from going forward.
Yeah. Don't lower the blood pressures or your undifferentiated strokes.
Mm-hmm.
Anything else you want to add?
Not in particular. Unless you had any other questions.
No, I think that was hopefully a pretty good summary. I know this probably, if you're still listening, thank you. I know we probably got into the weeds there a little bit, but hey, that's what we do, right? As always, well, here, what I'll do is I'll give it to you, and then I'll just say my usual spiel first, though. Just email us if you have questions. admin@alertmedic1.com, or comment on our social media. I mean, that's why we're here to, try to help understand and then answer questions. Did you have anything?
Nope.
Cool. Well, Dr. Brady, thank you for coming on again.
Of course.
For our listeners, by the time this comes out, our website, alertmedic1.com, is up. Well, it's already up, but by the time this will come out, it'll definitely be up. So make sure I haven't started doing anything with like email capture or anything like that, but we do eventually want to have like an email list, which will be fun just to like get out like articles and stuff like that. Josh and the team are doing an awesome job at our social media. So if you're not following us already, follow us on Instagram. I believe it's at alertmedic1. Follow us on Spotify. That would be helpful. And then tell a friend. And we're always looking for people to come on the show too. I guess I should mention that. If you have an idea or want to come on the show, just fans, or I'll talk to anybody. I can't promise we'll publish your episode, but I'll talk to anybody. Email us at admin@alertmedic1.com, or shoot us in a DM. But all right, thanks everyone for listening. That's all for now. Hold on, let me stop. Where's my mouse? Crap, there it is.